Hi everybody, this is Wendy Lokanc-Diluzio. Congratulations, you've made it to the final week in this course. I'm giving you all fist bumps and high fives. In this presentation, I will provide a snapshot of some of the specific populations that may be at higher risk for poor sexual health outcomes. So what's ahead? In this presentation, I will briefly discuss the following population: sex trade workers, new immigrants, injection drug users, inmates at correctional facilities, the unwilling or unable population, Indigenous people, people with disabilities, MSM population. Street-involved youth is a population of interest of mine. There will be a different presentation for street-involved youth. Something I'd like to say is that although some populations are shown to perhaps be at risk for poor sexual health outcomes, it's really important that we never make assumptions about people just because they may be part of a population. So I just think it's important to take all of this information with a grain of salt and again, not make assumptions about people. Sex trade workers. Sex trade workers are at an increased risk for contracting and spreading sexually transmitted and bloodborne infections for several reasons. These reasons include having a high number of sexual partners, limited ability to access social, health, and legal services, lifestyle risks such as substance use, and limited economic resources. Condom use varies among sex trade workers, and the choice to use condoms may be controlled by the customer. Customers often refuse to use condoms or offer additional money for condomless sex. Sexual violence is prevalent among sex trade workers. In a study of Winnipeg sex trade workers, about 58% of bad date reports included some form of sexual violence. So, for example, refusal to use a condom, unwanted touching, or sexual assault. Injection drug users. Injection drug users represent a growing concern for healthcare professionals because the craving for another hit overrides the importance of using a clean needle to prevent the transmission of HIV, hepatitis B, or hepatitis C. Offering better access to condoms and clean needles or drug equipment via needle exchange programs and safer injection facilities may help these populations lower their risk of contracting HIV while they search for an effective treatment. And we discussed safer injection facilities and needle exchange programs a couple of weeks ago in the STBBI module. New immigrants. In 2013, nearly 260,000 immigrants became permanent Canadian residents. Citizenship and Immigration Canada requires syphilis and HIV testing for immigrants and refugees over the age of 15 seeking Canadian citizenship. HIV testing is also required for children born to a mother infected with HIV, those with blood or blood product exposure, or those who may be an international adoptee. Presently, syphilis and HIV testing are the only compulsory STI tests for immigrants and refugees applying to become citizens. According to the Immigration and Refugee Protection Act, immigrants are not allowed to come to Canada if they have conditions or illnesses that pose a danger to Canadians or are very expensive to treat in Canada. Language, cultural, socioeconomical, and education barriers may deter certain immigrant subpopulations from seeking health services. New immigrants are overwhelmed with adapting to new cultural and healthcare practices, and many come from countries where HIV, hepatitis, and other STIs are more prevalent and treatment is inaccessible. Cultural beliefs may also influence a person's motivation to access health services. Some may try a variety of herbs or culturally accepted medications before seeking a medical treatment for an STI or HIV. Many Canadian provinces lack services and resources that are translated, culturally safe, and accessible to newcomers. It's important that those working in the healthcare professions are attentive to the stressful and complex issues faced by immigrants as they integrate into Canadian culture. The unwilling or unable population. Some researchers have identified that some HIV positive individuals are recalcitrant or unable or unwilling to prevent the spread of HIV. And for example, what this would mean is they refuse to disclose HIV positive status to their sexual partners. The research has determined these individuals often present with one or more of the following issues. So there might be psychiatric issues such as depression, fetal alcohol spectrum disorder. There might be addictions, social deficits such as lack of support in housing, involvement in the sex trade, and there might be health deficits such as lack of HIV knowledge. Researchers believe these variables contribute to higher risk activities such as having sex without a condom and can impede a person's efficacy at implementing risk or harm reduction practices. Health regions across Canada are addressing this issue in different ways, ranging from implementing comprehensive referral systems to providing housing and treatment. Inmates in correctional facilities. Inmates in Canada's correctional facilities have disproportionately high rates of STIs and blood-borne pathogens, including HIV, hepatitis B and C. People in corrections facilities may be from populations participating in high-risk behaviors such as injection drug use, other substance abuse, and unprotected sex. Also, those inmates who have consensual or non-consensual sexual contact or participate in practices such as injection drug use or tattooing or piercing while incarcerated are at risk for becoming infected and contributing to disease transmission. At the end of 2008, in Canadian federal penitentiaries, about 2% of the population were known to be living with HIV, and about 30% were known to be infected with hepatitis C. However, lack of routine screening for STIs and bloodborne pathogens are likely to result in underestimates of the actual infection rates. The time of incarceration presents a public health opportunity. Upon admission and during the period of incarceration, Correctional Services Canada offers voluntary infectious disease testing, pre- and post-test counseling, treatment, and access to medical specialists. STI prevention programs offering education, voluntary testing and counseling, drug dependence treatment, and harm reduction strategies have been proven to reduce STI and HIV risk in prisons. Since most inmates return to the community, those health practitioners working in the communities are positioned to coordinate STI prevention and discharge strategies to support healthy transition back to public life. Indigenous people. According to the Canadian National Household Survey, it's estimated that 4.3% of the Canadian population self-identify as Indigenous. Indigenous is a broad term that comprises First Nations, Inuit, and Métis people. The current health status of Canadian Indigenous people is remarkably lower in comparison to their ancestors. This population has been greatly affected by colonization, residential schooling, the 60s scoop, and systemic racism, resulting in lower health and education outcomes, which have greatly impacted all aspects of health, including sexual health. Indigenous people have disproportionately high rates of HIV compared to non-Indigenous people in Canada. In 2014, compared to other ethnicities, Indigenous people were 2.7 times more likely to get HIV. Furthermore, in 2011, this population accounted for about 12% of all new Canadian HIV infections and approximately 9% of all HIV-positive persons. Traditional strategies to prevent STBBIs within Indigenous contexts should benefit or could benefit from recent insights and interests surrounding syndemics. Anderman in 2017 defined syndemics as a conceptual framework for understanding diseases or health conditions and how these are exacerbated by the social, economic, environmental, and political milieu in which a population is immersed. Using traditional strategies to prevent and control STBBIs are not always effective, particularly with populations who are disadvantaged and marginalized. Anderman advocates for a broader approach which analyzes the manner in which systems and policies prevent or support effective responses and recognizes the structural changes necessary to develop environments that are supportive while increasing resilience of the population. Regardless of the type of STBBI, it's important for us to acknowledge the following. A, the social determinants of health impact STBBI rates. B, traditional strategies to control STBBIs are needed, but they're not enough. And C, by using a syndemic lens, we can influence action at several levels to address the root causes of ill health and create strategies that are more effective for improving the health of Indigenous people while lessening health inequities. People with disabilities. Although all Canadians have a right to comprehensive sexuality education, children and youth with disabilities do not always receive it. Children and youth with disabilities experience the physical, social, and emotional changes that are part of growing into a healthy adult in similar ways to their typically developing or able-bodied siblings and peers. Sometimes, however, they miss out on learning about sexuality as parents and service providers focus on other life skills and don't feel supported to talk about sexuality. Youth with disabilities who do not receive sexuality education that is inclusive to their needs are vulnerable to abuse, sexual exploitation, sexually transmitted and bloodborne infections, social isolation, and lower quality of life. MSM population. Following a decrease in the prevalence of reportable STBBIs among MSM beginning in the 1980s, the incidence of syphilis, gonorrhea, chlamydia, genital herpes, hepatitis B, hepatitis C, and HIV infections has risen among MSM in Canada, as well as in international populations since the mid-1990s. Recent outbreaks of syphilis among MSM have been reported, with a large proportion of co-infected cases with HIV. Rising rates of STBBIs among MSM are associated with increases in unsafe sexual practices. Some explanations for risky sexual practices among this group include fatigue with safer sex messages and reduced fear of acquiring HIV due to optimism about new HIV treatments. Although the correlation with treatment optimism has not been shown consistently, the increase in unsafe sexual practices among HIV-infected MSM has been attributed in part to the increasing proportion of HIV-infected MSM who feel healthy, are living longer, and are therefore having sex more often and with more partners. Lack of knowledge of their own and their partner's STBBI status, including HIV, is also a contributing factor. Thanks for listening. Again, this was a quick overview on some of the populations at greater risk for poor sexual health outcomes. Please feel free to email me if you have any questions.